75% of the hospitals are telling us they have no essential supplies. I'm not talking about fancy things. I'm talking about things like strapping, gloves. We are talking about paracetamol, painkillers, basic antibiotics. Hospitals are telling us, and 3/4 of the hospitals are saying we don't have these supplies.
3/4 of hospitals.
Now, and I can imagine these are private and FBO hospitals.
What's the situation in public?
I do not want to think about the situation in public hospitals because of the the convoluted procurement there. Hospitals are telling us, private hospitals and faith-based hospitals, they are telling us that suppliers, they can't pay payroll. And 90% of them said this. We are not able to meet payroll and we can't pay suppliers. Now, okay, let me even finish that. I say a third of them told us that they are at risk of auction. Like auctioneers are knocking on their doors and, it's crazy. Another quarter, almost 25%, told us that they have cases in the small claims court. Now, these are not... the distress is beyond banks because for banks it was 2/3 of them said we can't pay our bank loans and overdrafts, but now they have gotten into small claims court. Now you can look at a provider who is spending their time running after suppliers, keeping the banks away.
An estimated 1.1 million Kenyans fall into poverty each year, and that's because of healthcare costs. Would SHIF UHC change that, or is there more? Or perhaps, what's the difference between a pharmacy with a blue cross and a green cross? What about cancer and the rising incidence amongst the youth? Is it just lifestyle changes, or is there more?
Women's health, men's health, your children's health, the economy, this and more awaits you on season 2 of Kenya's favorite health podcast.
My name is Dr. Diana Wangari-Gitau, and welcome to season 2 of the One Health Lens podcast.
Hello, welcome to the One Health Lens podcast, where we have conversations around health and related topics, making them simple and easy for you to understand. I'm your host, Dr. Diana Wangari-Gitau.
And I am Dr. Simon Moshara Kegodu.
Hey, this energy has been maintained.
We're
maintaining that energy. I tell you, it's going to be a hot conversation. I mean, it's 30 days since the transition from NHIF to SHIF and all this healthcare reforms that are happening in Kenya. And we want to understand what's been happening from the perspective of the providers, from the perspective of a concerned citizen. And just know, I mean, what's fact, what's fiction? Do we know what's happening? I mean, let's just listen. As always, we have in studio with us very important guests. I'll let them introduce themselves and then we'll get going. Doc?
Thank you so much for having me back here, Daktari and the Daktari. It's a pleasure. I always enjoy this podcast. Very open environment for exchange. My name is Dr. Brian Lishenga, chairperson of the Rural and Urban Private Hospital Association of Kenya, and happy to be here today.
Karibu, I'm expecting to hear what's been happening.
Yes. I feel like I have not been given an opportunity in the recent days to ventilate. so if I get a bit dramatic, it is catharsis, the information. Yeah, but yes, quite a bit to share, and hopefully we can do it in the time that's available.
Okay, fine. If not, you'll need to come back again.
Okay.
Cairo, Karibu again.
Yeah, thank you so much. My name is Beatrice Cairo, a health economist, a politist, and a policy influencer, fighting for rights of every Kenyan. And health is a human right. No Kenyan deserves to die because of bad policies. And I'm back. I'm glad to be back here. I think I've been proven right based on I think the last time I tried to point out various issues affecting this SHA. And 30 days down the line, those are the same things, the same Kenyans went out there to talk about them. And I'm glad here we see what's the way forward. How can we help this government, because we're already here now. Now we have to make it better. And I want to remember that there is this MP that is from Rango MP, that was Lillian Gongo. She's a politician, and she had to defend the patient in front of the president and tell him the truth on his face. And one of the things she raised was that, why are we shifting policy to another policy? And yet healthcare in its essence is not like education, whereby every minute, every second, a patient dies, and that life cannot be gained back, and it will leave a lasting impression on that person who has lost that individual. And she actually was so bold enough to actually tell the president, let me tell you the truth. And she even told Raila Odinga, I have to stand here and tell the president the truth, because it seems nobody is actually telling him the truth.
You're here to tell us the truth.
Yes.
That's Cairo.
Yes.
Here to tell us the truth.
Yes.
Lishanga, have you registered for SHIF?
Yes. Yes,
Okay.
yes. I did it as a part of proof of concept.
You had to test the system.
Gotta test
me
the
too.
system.
No, me too.
Yeah,
Yeah.
you know, I have to test the system. I have to put it to the test. So I ran through it. I was trying to find out if it's gonna be easy for an ordinary Kenyan to register. Now, considering that I have the privilege of knowing a lot about the process, so I figured if it is difficult for me, it's gonna be impossible for the common mwananchi. So I did it for that purpose, to just experience the process. And I got a PDF on email saying I am registered. I noted that that process did not include my dependents being uploaded at that stage. I think I was one of the early ones. So yes, I have registered, but I know there is still a problem somewhere. I need to put my dependents in the system. So yeah, I think the process of registration, if you are say moderately, internet savvy or something, you can do it. My worry is that how many Kenyans are like that, who can navigate an internet portal easily. So I think I see a lot of people, setting up third-party support systems, which will incur cost just to help. The cyber cafe issues where you say help you with your KRA, help you. So I see a black market sort of for share registration emerging out of this. I also see a lot of unintended discrimination based on which parts of the country where there's internet. So there are still parts of Kenya where there are no cyber cafes.
True.
And they believe it or not, there's a lot of Kenyans who don't have smartphones that you can log into a site. And also digital literacy is still a major problem. So I think that the intention of the intention was good in terms of taking us to the 21st century for onboarding, but it should have come with a backup 20th century formulas, considerations of how to register. I am just thinking of my people at home in my village where I come from, and I think it is going to be impossible for them to register. And then they will incur cost to register because, as I've said, once you realize you can't do it, you need to be handheld. Then you will end up in some cyber cafe. And how do you price a service which you don't know? So if somebody tells you share registration is 500 bob or 1,000 bob, what will you do? You pay. So
you bring up a very important point, because I've always brought this. I pay healthcare for my parents, and I used to pay the NHIF. And now this time they needed to go to hospital, and they went and came back. And me, having proof of concept, so to speak, having registered into SHA, it was, you need to be tech savvy, literally. So I asked the hospital to help my parents register, and they were still unable. They were being told, okay, let's try this on Monday. An OTP will be sent. You say, so up to today, because I haven't been able, I'm busy, I haven't been able to go and help them register. And you bring a very important point, and my parents are in Nairobi, where I have access to them with my gadgets.
Yeah.
So you bring a very important point, and another one you have just brought out, which I have then thought about, is information security. Those cyber cafes, you're giving your KRA pin, you're giving everything. I think there are some of the issues that we've been raising with Safaricom giving out our information, but other information actually at the point of registration. And which now, sorry for taking that over, brings up to another point when I was discussing with another colleague. He said, actually, Dr. Elizabeth Kitau, she said, why couldn't they say that you can go and register, for instance, at a Huduma center? You see, that would sort of, you spread them all over. Yeah, you know, the way you register for elections, you know, the service registration is facilitated. You see, as opposed to assuming all of you have a phone, all of you are tech savvy. Yeah. So that's a very good point, Lishenga.
But for me to interject, coming from people who are not tech savvy, where we are, I would say, the digitized, the Gen Z and the millennials, those who are tech savvy, majority will not register because the government has not convinced them about the privacy of their data. So personally, I've not registered into SHA because I don't trust this government to actually handle my data very well. Number two, and that was evidenced by forced transition, because how did they get my data? Through Safaricom. You know, someone actually raised a point and said there's a line they have never shared while registering for NHIF. They had a Safaricom line, but they didn't use it to register NHIF. But when SHA registration came on board, they were actually automatically transferred into SHA. So they said, how did they actually access my mobile phone number? So, and then we are at a season whereby now people are raising concern about Safaricom. Remember the abductions and all that. And Safaricom is actually having to defend itself that it actually does not share information about their clients. So the privacy of data, remember we have the Digital Act, which said that it's going to enforce privacy of data. Now, this is the same challenge KRA is also going to face, because who is going to actually support this database that we are actually going to hold our data? Now, NHIF, as many Kenyans did their own research, and even I doing my own research, it was being held somewhere in the UK by a group called Tata Group, which is an Indian group. Now, that means we as Kenyans don't have our own database. Yani, we have not yet set up a place where we can put all our records into one place. So it means at one point we can be held hostage and there's nothing you're going to do about it. So because of that, most Kenyans who are not tech savvy, I know we have talked about those people who are not tech savvy, but those who are like me who are tech savvy, we are feeling, I don't trust this government to actually handle my sensitive information. Now, last but not least, I'm looking at how when you look at the way our healthcare network has been set up, especially for the public sector. I don't want to talk much about the private sector. We know some counties even did not even used to have a HMIS system. They are still doing those register books, you know, those ones that you record the patient and all that for a very long time, even up to date. So I'm wondering, now that we have gone into these transitions, what happens to those remote places that are going to actually, they're telling you to come with the SHA card or the SHA number. And that was experienced in Turkana, where now people are reaching to a point like, what is this SHA thing? Is actually now the perception people are now having is that this government is out to kill us, because you are clearly demanding from us even a small health center. You know, some health centers are even almost falling off. I hope you saw in the Citizen news, or no, in the social media news, there was a health dispensary in Turkana. The roofs were almost falling off. They don't even have electricity, and yet now you're telling us it's going to be a hub and a spoke together into a referral system that is going to be integrated. So because of such challenges, I think this government should have first and foremost set up a database, because even government itself, these systems of government, whether it's treasury or wherever, remember, I think it was 2 years ago, they were hacked by Sudanese, because we were trying to interfere into their issues, and the next thing, they had hacked even the grid system of electricity. It tells you definitely we are yet to be secure when it comes to data privacy in the country.
I mean, Cairo has highlighted a lot of the challenges we've been seeing in this 30-day period, right? Which anyone looking at it will say there was a poor transition plan. There's a poor transition plan. And so the question begs, let me start it off as a general question. What has been happening from a provider perspective? Because it's very easy for people to say maybe it's hospitals turning away patients, maybe it's hospitals being greedy. What has been happening?
So this is a very good question, and what we have been doing as an association is we try to be as objective as possible about this process, so that we made a decision that we will share information that is as factual as possible about provider experience. And we have, since the first week of October, been surveying healthcare providers and asking them to tell us how it's going on. Our latest survey came out on 31st, on 3 days ago, and I will so this latest survey was intended to just give us a 1 month overview of what's been going on. And what I can tell you is that it's a mixed bag, you know. So if you asked me why, speaking from a very, you know, bird's eye view, very, you know, why is there a challenge in the country with why are patients complaining? Why is there such, you know, public outcry? And what is the role of hospitals, both public, private, and mission, in this outcry? I would say that there are several aspects. One is that the management of the transition, which has been the transition has actually been a system switch. When people talk about it, it's really at the core of it, it's change of systems. One system that we have been using to manage beneficiaries to a new system entirely to manage beneficiaries. That has not been seamless. It's been very difficult, and communication has broken down. I like what a colleague of mine said. The term they use is, during changeover of systems, what you need to provide as the initiator of change is hypercare. You know, you need to have, like, for instance, 24/7 call centers. You know, you need to have teams which are available weekend, are available at 1 a.m., 3 a.m. at the night. You need to have calls which never go more than 3 dial tones before they are picked. You need to have boots on the ground supporting providers and patients physically. So this, until the system stabilizes, needs to be the approach. We need to have been provided with more care than we are usually. In fact, the healthcare system should have been flooded with care, you know, so that they shepherd the transition. Unfortunately, part of the outcry is that even if you argue that the ICT system is better than the last one, if you don't provide care in the transition, the judgment will be that the ICT system is bad because of negative user experience. So one big issue has been the lack of care or suboptimal care provided to both patients and hospitals during the switch of from one system to another. And that is the cry you are hearing. Because I go to a hospital and all of a sudden you don't have my details. Okay, that's fine. If only I could make a call and my details appear, you know. But if you don't give me a number, you don't publicize it. And when I do finally, after many hours of search, find the number, no one picks the number. It's unavailable over the weekends, it's unavailable at night. This is the outcry. The second issue is that we decided to do this very ambitious endeavor that I've just described, this switch, when hospitals, and I'm saying hospitals regardless of ownership, when hospitals were in dire distress, you know, so you are loading a system that is already in distress with a big change, you know. So here it's like a patient who is in kidney failure and you decide to take them for surgery, you know, and then you have no pre-op preparation.
It's like going to theater.
Yes.
Use that example.
Yes. And then you ignore the anesthesiologist report.
Like, no, we're going ahead.
They're telling you this urea is high, you know, this potassium is crazy, and you're like, you know, we've done this before, you know. So and then you go cut, and then your patient is flatlining on the table,
But you're cutting.
and you're cutting. Yes, and you're saying no. You know, this surgeon of ours is from the best hospital in India.
Let's proceed.
Patient is gasping, you know. Proceed, you know. So this is literally how we have managed the transition from a healthcare provider point of view. And you know, if you talk to most hospitals, they will tell you they think this patient is dying. You know, and some of them have literally given up, and they have said it's a situation, we're not coming back from this. Now, so the distress is, one, the financial situation was very bad, and we have done an assessment of, we did both FBOs, faith-based hospitals, and private. So this is really a picture of the nation. And you know, I've seen some crazy things, like 75% of the hospitals are telling us they have no essential supplies. I'm not talking about fancy things. I'm talking about things like strapping, gloves, you know, we're talking about paracetamol, painkillers, basic antibiotics. Hospitals are telling us, and
they don't have
3/4
it.
of the hospitals are saying we don't have these supplies.
3/4 of hospitals.
Now, and I can imagine these are private and FBO hospitals.
What's the situation in public?
I do not want to think about the situation in public hospitals because of the, you know, the convoluted procurement there. Hospitals are telling us, private hospitals and faith-based hospitals, they are telling us that suppliers, they can't pay payroll. And 90% of them said this: we are not able to meet payroll, and we can't pay suppliers. Now, okay, let me even finish that. I say a third of them told us that they are at risk of auction. You know, like auctioneers are knocking on their doors, and you know, it's crazy. Another quarter, almost 25%, told us that they have cases in the small claims court. You know, now these are not. It's the distress is beyond banks, because for banks, it was 2/3 of them said we can't pay our bank loans and overdrafts. But now they have gotten into small claims court. Now you can look at a provider who is spending their time running after suppliers, keeping the banks away, going to court. Now this is the provider whom all of a sudden you have told them, hey, your portal is unavailable. Let me tell you, it's so bad, because you know the prior system, you used to log in and you could see, okay, I have 1 million claims at accounts payable, I have 500,000 at discharge, and I have 2 million at EFT. Right now, first the transition, they switched off that one. So providers don't know. First, you know, trust deficit. You imagine, you have a bank you own a bank account, you don't know the balance, you know, and they just switched it off one day, and then when you went to the bank,
they tell you
the tellers are missing. Okay, let me tell you what's happening here. So when you go to the NHIF branch is like now your bank, your local bank branch, the employees are being retrenched, you know, so they don't want to see you.
In fact, they're like, I don't work here anymore.
No, I don't work, and don't ask me these questions. You get? Don't know. Now, and the reason why you have come there physically is because you used to look at your balance kwa simu. Now the portal is gone, so you rush and say, can I check my balance? The employees can't tell you the balance, and then they tell you, call this number. You know what happened to people when Chase Bank was this is the same experience now for health sector providers. So if you are a hospital owner and this is what you were facing, and Cairo showed up for healthcare, you will tell her to pay cash.
Exactly.
It's a no-brainer that you will just tell her, look, I have no way of handling your case, but I can help you if you pay cash.
Cash.
So literally, I get sad when I hear some government officials saying that that these people who are doing this, they are anti-government. We will deregister them. It is corruption fighting back.
Yes.
Those kind of statements. Those kind of statements. They are making a toxic environment even more toxic, because as I started by saying, really what government should be doing is providing hypercare to providers. This is a time to bring them together, tell them, okay, fine, you're struggling with finances, let's prioritize the sector. I also have conversations with people at Ministry of Finance, and you know what they tell me? The economists there have not drawn a relationship between their economic decisions and the loss of life.
Yeah.
Because for them, they never see loss of life. Yeah. They see an Excel sheet.
True.
It's just they're just looking at numbers and saying, okay, I'm at risk of defaulting on this IMF thing. So if you tell them their children not being immunized, what are you talking about?
Is it in my Excel sheet?
It's not in the Excel sheet. There are no ARVs. So, how does this affect economic output? They can't draw the parallel. So, I would say I think that the transition team did not count the human cost of the transition.
That's such a good point. I mean, and there's a lot to unpack there, but I'll ask a more direct question. Why do you think that we do not even have access to the data? And I ask that because, one, there was an existing system before that was already collecting this data, right? We got notifications that we've been migrated. We're assuming that happened. So it should be, if I walk into a facility today, I should be able to, as the receptionist, whoever it is, right, should be able to have access to data, if only through the NHIF portal.
Because you're going to get me into trouble with this kind of questions. This kind of questions where, which you say something, then unapigiwa simu. So, we found out that 87% of hospitals are saying they have problems verifying patients. In other words, if you came to a hospital today, they have to either start your registration afresh, or they can't find a beneficiary. In fact, the group that is suffering the most, which is ironic, is the group that had prepaid their NHIF. So this for 2 years. So this for 2 years. So if you think about it, these are supposed to be model citizens. These are the guys who you should give a badge of honor or a medal.
They should be a red carpet.
They should be given a red carpet. This is the kind of people we want. But ironically, right now they are suffering the most because one, providers don't have visibility of your contribution history in the current portal. They don't have visibility of your beneficiaries. The reason why we are using one-time pins is because your fingerprint data that we had before was not migrated. So now the only other...
Oh, really?
Yes. Because now, why are we using one-time pin if you can put a fingerprint? You don't need. You are already registered. So one-time pin is a level of authentication, but an even higher level of authentication is fingerprint, isn't it? So why are we using one-time pin? It's because of database issues. Why are we missing dependents? Database issues. Why are people who contributed in advance being asked to pay new premiums instead of, as we had been promised, that their premium will be automatically transferred?
So why do you think that is the problem?
The reason why this is happening...
No, actually, one patient actually asked, like most Kenyans, remember when the public participation was being done, quote unquote, they were asking, where will our money go? This money we've been contributing. Remember, even you as an employee, there is still the money which was being deducted from your salary. So one of the questions they were asking is that, so that money we have been paying to NHIF, will it automatically be transferred? That was one. Then the other question, I know he'll answer us, was why am I being told to re-register? If you have my information, then it automatically, like when you lose your SIM card, when I go to Safaricom, I replace my SIM card, all my information goes back, right? But now these ones, when you tell me to go back online, re-register myself, it already brings mistrust. And then now, the way you're saying, my premiums, they already feel it has. Yeah.
Continue. So I was going to say that, to answer the question from Dr. Kigondo, why is that happening? So remember the statement where 12 million Kenyans were migrated.
Yes.
It's a brilliant move.
It's brilliant, isn't it? Shouldn't that make you pause and think, like, why are we having data mismatches if we migrated 12 million? I will tell you what I think. This is my pretty well informed guess. Is I think that the contract that was running NHIF is not transferable to SHA. That is what I think. Okay. And obviously these are very internal government transactions, but you can see the effect in the real world. The effect in the real world is that if there was a business agreement with whoever owned the HICS system, that business agreement has been terminated by the introduction of SHA. Now, how do you, or in an orderly manner, terminate one contract and enter into another contract in a situation where you have a narrow physical space? You know, I think that what might be happening is we are facing the effect of contractual relationships gone bad, you know, and unfortunately that is affecting patient care. I suspect that ultimately they will need to rebuild an entire database. I don't know how many years that will take them, and it's not gonna come cheap, which, you know, would beg the question about the involvement of the Apiero Group, Safaricom, and all these guys, and 104 billion.
Fact.
You know, so I mean, and I feel, and I feel I can say this without any contradiction, because guess what? All these guys published in press that they are doing it. I mean, Safaricom give out a press release saying we are investing in this. So my question would be, the partners who we were told are putting down money, why doesn't SHA have an ERP? Because for me it appears that the SHA does not have its own ERP to manage beneficiaries. You know, like,
what do you mean? But they have. What do you register into?
You are registering into HICS in the background.
Yeah. So the old NHIF system is what you're registering.
Yeah, okay, musinipeleke huko sana. What I will tell you,
I'm supporting.
Danger zone.
Danger zone. What I think is happening is, and it's tied to the point where I said that they have to rebuild an entire database. The company that is supposed to rebuild the entire database is known. You know, it is in a consortium. It is known.
Okay.
Have they put the money behind rebuilding the database?
Not yet.
My guess is that they haven't.
Okay.
You know, so where is your information going now? I think we are being extended a courtesy by HICS vendor.
So the old guys are saying, you know what, we hear the Kenyan suffering.
Yeah, let's help you.
Let's help you a little bit.
Yeah, but you do good by us.
So 104 billion.
But in that agreement, I think the Kenyan government should learn its lesson. So in the case where we stop needing your services, then you should not have any jurisdiction to hold our data.
Correct.
That's number one. So we need, because I know Senate is reviewing some of these agreements with the Adani Group and all that. I think to the Senate, this is the one area they should actually focus in that clause. One of the clauses should be in the year, because a new regime can come and we may no longer need your services, or you feel you are exploiting us, then we decide to stop it, then you do not have jurisdiction to withhold our data. That's number one. Number two, we need to have a backup. it's the high time the government decides to have a backup, because in such a case scenario where government has refused to pay the companies their money back, the 104 billion, you know how government goes. What happens? Will someone hold you hostage? So I think it's the right time right now to actually have that database, because this data is very, very much sensitive in terms of, now will we go back to square one? Someone will switch off a button and then they'll hold your government on hostage, and these are lives again. And last but not least, I think for healthcare is different. It's not like education system where a child may lose 1 year of school and gain it elsewhere. But once a life is lost, it's lost for good, and that's it. You can never bring that back life. And I think this is where these governments need to set up policies, and especially for agreements pertaining healthcare, even doing agreements with the county governments, doing agreements with private sector, whoever. So long as lives are being involved, we should have that actually that clause to ensure that there's proper transition. And in the future, if we decide, if people decide no longer to actually interact with these individuals, or someone may actually be trading your data for wrong reasons, you can terminate. But after you terminate, they go, they actually go with your data. That's one. Number two, can counties, they themselves also back their data up? You see, now we say health is devolved. Why should we have data at a centralized position? So that at least in case one is switched off from one end, Kenyans can have another. I know that's why I like devolution about healthcare. It means if one end you're closed, there's another county people can run to and have access to healthcare or access to. So let's have also autonomy of these counties when it comes to their own databases. Can each county also run and manage its own information? Last but not least, when SHA came on board, they did not factor in operation costs. Remember the issue with NHIF that was prior is even in the claims management. You'd find hospitals were losing a lot of money in terms of, because the person who is supposed to do the claims is the nurse who is working on that patient. The nurse is overworked. Then you go to the daktari. Daktari is also, and there's a queue of individuals. And that NHIF workers were also very little. I think some hospitals were colluding with NHIF and paying something small, so that person can be maintained within the hospital to actually enable them on how to do the claims. So when it comes to
what did you just say about
no, to assist them on how to manage their claims management, because some of them were actually very clueless. So because I remember I worked with one in Meru, and what they had done, they had someone hospital, they were called hospital administrators for NHIF. So what they were helping the hospital is how to manage their claims, how to fill forms properly, because there was a lot of overload of work. So with now SHA, what we are saying is that each county, I was actually giving the suggestion, out of all these 47 counties, why don't you set up small bases of SHA to actually work with these facilities? So when there is a problem, they could actually walk into that office and actually do the claim. Remember, the branches for NHIF were very minimal, and you had to go to headquarters and all that. So instead of everybody coming to the headquarters here, people can actually go to the nearest SHA offices, and even clients, even the patients, could actually walk in there and assist. Then when it comes to the hospital, are we going to hire people who will actually employed by SHA or employed by the hospital, where they can actually be doing the claims bit,
I mean,
so that you don't make it dependent on the healthcare workers.
I mean, it's part of any good change management. You need champions, you need all this.
Yeah.
But I'm going to suggest we're going to take a break, and then we're going to come back. We're going to come back. We'll see you in part 2.